So we'll pick up where we left off before. We're just going to start about how to characterize degenerative disc disease. Here's some old terminology that I don't use, and I don't really see it used very often in reports anymore. Kind of the normal disc that we talked about before. Notice you do get a little bit of normal bulging of the disc. That's okay. Spondylitis deformans is kind of early degenerative disease where you start losing water content within the nucleus pulposus. You start getting a little bit more bulging, some marginal osteophytes typically. You still have not a lot of loss of the height of the disc, and then intervertebral osteochondrosis where you get marked loss of height of the disc and desiccation of the entire disc. So I really think that most people should really use the North American Spine Society classification. There's a study published a number of years ago now that looked at the number of words used in the medical literature concerning degenerative disc disease, and there are over 58 different words used to talk about degenerative disc disease. And I think a lot of them are basically put in there for confusion, so that it's harder for people to actually compare apples to apples. So I think it's very worthwhile to use a standardized nomenclature, even though I don't completely agree with this one. So one of the hallmarks of degenerative disc disease are water loss or desiccation of the disc and disc herniations. And disc herniation is defined as a localized displacement of disc material beyond the limits of the intervertebral disc space. And it can either be generalized, which is often called a bulge, if it's greater than 180 degrees around the circumference, or localized if it's less than 180 degrees. And in the early degenerative disc disease, these are typically due to herniation of the nucleus pulposus, that gelatin that we talked about before, through tears in the annular fibers out to the periphery of the disc, and it's typically located in the posterior half of the disc when it's focal like this. So here we can see there's loss of the normal height, there's desiccation of the disc with loss of water, and this is a typical, more of an acute herniated nucleus pulposus, where we can see the water within that gelatinous component of disc that's extruded beyond the annular fibers here. This is seen really in acute disc herniations, as I described before. If there's enough fluid in this, the bioactive molecules can produce a severe inflammatory response up and down the spine, which can cause really severe pain. In the axial plane here, we can see some of the more fibrous annular fibers, and this is the extruded nucleus pulposus coming out here, producing marked compromise of the thicosac and the neurocanal. So, I don't want to say lowest level of this, but one is the symmetric bulge. We have bulging around everywhere. This is really degenerative disc disease, and it's generally thought not to be a surgical condition. You can get asymmetric bulging, but again, this is over 180 degrees around the circumference of the disc, a degenerative bulge. Again, surgery has not been shown to be helpful in this particular disease. You can also get herniations into the end plates, which we call typically Schmorl nodes, which this classification calls an intervertebral disc herniation going into the vertebral body itself. Now, more important for what we're interested in are more the localized herniations that are less than 180 degrees. And these, according to this definition, if it's broad-based, it's greater than 90 degrees, but less than 180 degrees. Typically, I like to use mostly less than 30 degrees. And greater than 30 degrees, but their classification is if it's less than a quarter of the circumference of the disc, then it's considered a focal herniation. So there's a normal disc. Usually the focal herniations are over here, or sometimes they're right in the midline. And so a focal herniation would look like this. A broad-based one would look more like this. And the differentiation here is that, again, typically the broad-based herniations are not surgical candidates, but the focal ones may be surgical candidates if it's compressing a neurologic structure and is causing symptoms. So usually by the time we see a focal herniation of the disc, or now, in terms of herniation, the North American Spine Society says these are all herniations. Many people prefer not to use the term herniation in a report because herniation tends to be one of those words which implies surgical management, even though it shouldn't. So what the North American Spine Society really emphasizes is calling these either broad-based or focal protrusions. So here would be a focal protrusion because it's less than 180 degrees, less than 30 degrees in this particular case. It's focally here in the midline. So this would be a focal protrusion. And then some people like to do two measurements. Most people only give one measurement. They just give the anterior-posterior measurement, or the measurement of how much it protrudes beyond the margins of the vertebral body. And the lateral diameter isn't considered that important. It's often difficult to accurately estimate. So most people just say it's a focal protrusion. They say where it's located, in this case centrally. Now I'll show you the different nomenclature for where it's located in a minute, and then determine whether it's affecting one of the nerve roots. So this would be a focal central disc protrusion, in this case with normal signal intensity. And because it has normal signal intensity, it's a focal protrusion, it's possible that this could be an acute lesion. Now, acute is a difficult thing to say. I tend not to put that in reports because, and in general, something like an automobile accident, biomechanical studies have shown that it's highly unlikely that you'll get the kind of forces on the discs in an automobile accident that actually produces acute loading, increased pressure, and an acute herniation. Though, as you get out in practice, you'll find that a lot of people want to imply that for other reasons. But so this is a focal protrusion. So a protrusion is defined as present if the greatest distance in any direction between the edges of the disc material beyond the disc base is less than the distance between the edges of the base. Make a lot of sense? Mm-hmm. Or it's basically is wider than it is deep. That's a protrusion. Now, an extrusion is basically something that's deeper than it is wide. So a protrusion, the width is greater than the degree of protrusion. In an extrusion, the width is less than or equal to the degree of extrusion. So that's by definition how you define those two. An extrusion is thought to be much more likely to be symptomatic and much more likely to be a caused by some sort of increased pressure or trauma to the spine. So these are just examples of extrusions, and if you see it in any direction, then it can be an extrusion. Here, this is deeper than it is wide. In this case, it's also extruding out beyond the confines of the vertebral body. Okay, so then if we look at studies here, we can see a focal extrusion. We can see that it's migrating superiorly and inferior. And by the way, if it goes away from the location of the disc space, that's called migration under this terminology. So there we can see a focal extrusion. And then another term that they use is contained versus uncontained. So a herniated disc may be contained or uncontained depending upon whether or not the displaced disc tissues are wholly held with intact of the outer annulus. A disc with a contained herniation would not leak fluid injected into the disc into the intervertebral canal. So basically then if we look at John still hasn't joined us. Here we can see the different annular fibers and Sharpie's fibers around the periphery. And here we can see that the annulus is intact and would be watertight. This is the posterior longitudinal ligament here. That's further extrusion or herniation of nuclear material. And here we're actually almost going through the annular fibers, but not quite. Posterior longitudinal ligament is intact. Here it's extended all the way through the annular fibers. And therefore, if you have fluid here, it could leak out into the extradural space. So this would be non-contained, and the others would be contained. That really has meaning if you do a discogram, which hopefully we're not doing anymore. By MR, we can't really see this, so I don't think it's an important criteria for MR. And then we have migration. Just 1 second. Let me call John and see what's happening here. Okay. So the next is migration, where the nuclear material can move away from the site of extrusion. And here we can see, here's a non-migrated disc, and here we can see migration of the nuclear components here external to the posterior longitudinal ligament going inferiorly from the disc. And this is what it looks like on gross specimen here. Here you can see the nucleus pulposus extruding out where it's contained by the posterior longitudinal ligament, but no longer contained by the annular fibers. And then here's just an example of an extruded disc migrating superiorly all the way up to the disc base above it. And we can see the marked mass effect it has upon the neural canal and the shifting of the nerve roots to the opposite side. And this will also stretch and compress the nerve roots on the ipsilateral side in this case. So that's a disc extrusion. And then here's another extruded disc which is extending out into the neural canal. And here we can see it actually extending posterior to the nerve roots in this case. The next term that the North American Spine Society uses is the term sequestration. It's an extruded disc where the disc material has lost any continuity with the parent disc. So here is an extruded disc, here's an extruded migrated disc, and here's an extruded migrated disc with a sequestered fragment, which is no longer physically connected to the original disc. So this would be a sequestered fragment. And there we can see a nice sequestered fragment separated from its disc. Now, this used to be considered kind of the worst form of disease, and that this was an indication for surgery because it compressed the nerve roots. But that's no longer the case, and I'll explain that when we get to some of the literature where this has been reviewed. Now, other things that the North American Spine Society, other ways to describe it, is the amount of compromise of the volume of the neural canal, mild, moderate, and severe. I really don't think these are very useful, and that's because people have different size of neural canal, and I think you can often get severe compromise of the nerve roots even when it's a third or only of the canal. What's really important is the amount of CSF surrounding the nerve roots. And if you have a tight canal from congenital stenosis, or you have a lot of degenerative osteophytes, then a extruded disc of a smaller volume can have the same effect upon the neural structures. So instead of using this, I like to see the amount of CSF surrounding the nerve roots. Severe is where you see, at the level of the disc extrusion, you see no CSF. Moderate is where there's very little CSF. Mild is where you still see a lot of CSF, and you can see the nerve roots have displaced away from the extruded disc. And then the location. And the location is both superior and inferior location as well as circumferential location. And here, what they like to do is evaluate whether the disc is located above the pedicle, at the level of the pedicle, below the pedicle, or at the disc level. And then that's up and down. Most of the discs are going to be at the disc level, and if it migrates, it can migrate to these other levels, or if you have a sequestered disc, you can describe it at these other levels. More commonly, what you need to determine is it in the central zone, is it in the subarticular zone, which is to the midline. Most radiologists call this the lateral recess area. whether it's in the foraminal zone, that is where the nerve roots are coming out through the foramina, or is it lateral to the foraminal zone in the extraforaminal zone. So I like to use central, subarticular, foraminal, and extraforaminal when you see in the axial plane the location of the disc protrusion. As we'll see later, in terms of symptoms for patients, the only one that is really important is the foraminal zone protrusion. They are more likely to produce symptoms than the others, and we'll go through the data that shows that. In the axial plane, then, this would be central, this is the subarticular, this is the foraminal, and that's the extraforaminal or far lateral zone. Some people call this the lateral recess, some people call this the pedicle zone, and some people call it the far lateral zone. But I tried to use the North American Spine Society termination when I do these. And then just a level if you have the superior inferiorly. I don't really use this very much in my reports. So here we have the case we saw earlier, central focal protrusion, and central being in the central zone in this area. And we can see that there's no displacement or deformity of the nerve roots, and the thecal sac is not deformed, not affected. Okay. What do you think of this one? How would you describe it?
Okay, so there is a central left or a central disc extrusion compressing on the left sided thecal sac and the nerve root, which is pushing, yeah.
So in this case, I would just say that there's mild encroachment on the thecal sac, but there is displacement and deformity of the transiting left L5 root.
Right.
And most, I don't think there's great studies about this, but in general, if there's deformity of the normal rounded contour of the nerve root, then some people believe that's more likely to be symptomatic than the others. Or if it's displaced, some people believe if it touches it and displaces, it's likely to produce symptoms. But I've not seen any really good data to really prove that. I think that's more kind of what some people think.
Is this going to be L5 or S1 at this level?
I think this is the L5 S1 level. The way it's angled. See, this is the level right here, and it's angled back a little bit. So this is L5 and this is S1.
No, the nerve root that's displayed.
Oh, it's going to be the S1 root.
S1.
This is the S1
Yeah.
root. Right, the transiting S1 root. I'm sorry if I said the wrong one. This is the transiting S1 root. Thank you. Okay. And then here we can see that you can get new protrusion. This is a year and a half apart. And we can see at this level we've got degenerative discs, but here we have a central protrusion that wasn't there a year and a half before. And that's what it looks like on the T1 weighted images. And the patient had no surgery. So this is a 26-year-old professional hockey player with right L5 radiculopathy. Sam, what do you think of this one?
There's a focal posterior, just maybe right to the midline, disc protrusion, and it looks like it's contacting the...
Okay. So this is not a protrusion, right? Based upon what we just talked about, what would this be?
It's a extrusion.
It's an extrusion with about 5 millimeters of
inferior migration.
Right?
Okay. Yeah, on the axial it looks like it's pretty broad-based, but yeah, on the... It looks pretty broad-based to me on the axial, but I could see how on the sagittal it would be a...
Well,
extrusion.
this is about as deep as it is wide. That would make it an extrusion. Right? It has to be wider than it is deep to be a protrusion. In this particular case, if you measure it all the way down here, and it's in any plane, so here you can see that it's much deeper than it is wide. If you look at the sagittal plane. Okay. So this was on 11/29/09. Okay.
Okay.
So we have, notice a fairly low intensity, so it looks like it's you got a lot of desiccation in the nuclear components here, and we've got some loss of disc height, in part maybe due to some of the nucleus pulposus being extruded, in part because it's just dehydrated, and we see some dehydration at L5S1. So this was on 11/23/09. He continued to play hockey and came back with severe pain a few weeks later, and this is what the study looked like. What's going on here?
So it looks like there was ongoing extrusion, and maybe it's sequestered now inside of the...
you can debate about whether it's sequestered or not. There is a plane between the annular fibers here and the disc. So you could debate whether it's sequestered or not. It doesn't really matter. It's basically what you have is nuclear materials have extruded out beyond the disc itself. So I think it's reasonable to call this a sequestered disc, even though technically it's not displaced from the disc. Right? So I think technically it wouldn't be considered a sequestration, but it would be an extruded nucleus pulposus. And we can see, comparing the two, there's more water in this one, and we can see it's larger than it was before. And so we thought it was sequestered. So that was further extrusion of material. And so this is one of the things that shows here is if you continue to have increased pressure on the disc, you can continue to extrude more and more nuclear material until there is some healing of the annular tear. This person ended up having surgery because it was getting larger and the symptoms were more, and they felt he could get back to hockey faster with very mini surgery. And here we can see a central and a right subarticular disc extrusion here in this particular patient. This is the same patient in the other plane. Here we can see that it's a extruded disc. Okay, and here's more disc with migration and this degenerative spine. Okay, let's see. Pablo's not with us yet. Shiv, what do you think of this case?
56-year-old with chronic back pain. So the sagittal MRI looks like there's a disc extrusion and a significant loss of disc height at that level. But then on the CT, it looks like it's calcified.
Yeah. So this just points out that we have these chronic discs can actually calcify, and here's the axial plane showing calcification of this extruded disc. That's pretty uncommon, but it can occur. Okay, Thomas, what do you think of this case? They're concerned about a mass in this case, actually.
Right. So, yeah, it looks like a focal protrusion at centrally.
Centrally here.
Yeah.
Well, this is probably the edge of the thecal sac right there.
Oh, I guess the left neural foramina.
What's this?
Completely effaced. Yeah, it's effaced.
What's that? And what's this?
Yeah, it's effacement of fat at the left neural foramen.
Wait, what do you think this is?
Could be a perineural cyst.
Coming from what?
I think from the nerve sheath.
Okay. Here's some more images. I think that's the same patient. What do you think about it now? I'm sorry. I'm sorry. Actually, forget it. I think this is another case. This is actually a disc fragment, a migrated disc fragment, which is compressing the nerve root here.
Okay.
Yeah. It was a disc extrusion here, and this is a sequestered fragment, which is sitting down here on top of the pedicle, and it's compressing the nerve root, and it's in the foraminal zone. And here you can see the normal nerve root on the other side, and you can see this completely effaces the fat and compresses the nerve root here. And this was a sequestered extruded disc.
Could you just say foraminal extrusion? Why all the other stuff? What makes you think all the other stuff is migrated and sequestered?
Okay. Well, it's a focal disc extrusion. And in this particular case, and it's going into the foraminal zone and it's compressing the nerve root. That's what we just said.
Okay, The migrating part of this.
So it's migrated because it's out here in the foramen. It's not next to the disc anymore. It's extended into the foramen. And see, it's way out here, compressing the nerve root. So it'd be sticking out here. Okay.
Is this the case, or it has the answer?
Yeah, this just shows that when you get a disc extrusion, you get an inflammatory reaction around it with some scar tissue which can enhance. And so this is the classic enhancement pattern that you see in an extruded disc. And presumably, if it's a scar tissue after surgery, it'd be more uniform enhancement. But as we talked about before, I think that's very unreliable. But this is the classic enhancement pattern that you see in a sequestered disc, this peripheral enhancement pattern. Okay, and then this just shows a lower thoracic central focal extrusion, which is then deforming and compressing the conus. So this can have significant symptoms. And that just then shows a extruded disc, which is going up into the foramen, compressing the nerve root, and we can see the foraminal component of the extruded disc on the left here, the right being normal. And again, another extruded disc. So I don't know, I've got all the answers here. I have to go back and change this so I don't give all the answers out. Another extruded disc on the right side, normal on the left side, and we can see compression of the disc over there. And then you can get extraforaminal zone extrusions as well. Here we can see, or the far lateral zone, as some people say. And there's a case where we can see the typical enhancement pattern that you see on a far lateral disc extrusion in this particular case. Okay.
43-year-old female with right lower extremity pain and weakness after a lifting injury. I think the problem is at L2, L3. Yeah. No, the level above it.
The other three?
Yeah, I think so. Yeah, there.
Okay. So here we can see the disc extrusion there, little enhancement pattern around it. And here's what it looks like on the axis images. We can see a focal disc extrusion here on the right side in the foraminal zone where it's more likely to compress. And here's the enhancement pattern around it, compressing the nerve root. And then there's another far lateral or extraforaminal zone. Okay. So here's a case. The other thing that you can see if you have compromise of a nerve root, sometimes you can see edema and increase in size of the nerve root if you follow the nerve root. Not very common, but if you have compression of the nerve root, just like if you have compression syndromes in the peripheral nerves for other reasons, you can get swelling before and distal to the nerve root. Okay. So what do you think here?
Okay, so at L5S1 there is some mild retrolisthesis of L5 on S1 and plate changes and disc protrusion at that level with the loss of height.
These are all post-contrast images.
Right, some enhancement of the left, what do you call the nerve root over there.
So we can see that this is a bright nerve root coming all the way down here. And there we can see it there, here,
enhancing
and it's thickened in this location. So if you get a compression of a nerve root, sometimes it can enhance and it can become thickened. And some people at one time gave contrast because if they saw nerve root enhancement, they thought that might be an indication for surgery. And I don't think that's really panned out to be a good indication for surgery either.
Extensive enhancement.
Yeah. Because then we found that we could see a lot of enhancement patterns of nerve roots without showing that there was actually compression of the nerve root. so it's unclear. Can be caused by a number of other different things. So, some people used to give it to try to say that we'll operate at that level if that's the case, but that pretty much did not pan out to be a good reason for surgery. Okay, Sam, what do you think of this case?
So this desiccation inferiorly, and I think what looks like an extrusion and inferior migration of the L5S1 disc. Yeah, sure enough. Oh, and it's enhancing. So, yeah, on the left there. Yeah.
Some patients did not have surgery, so this is just a uniformly enhancing disc. And again, whether it's uniform or not may in part depend upon how long you wait after you give the contrast before you do the imaging. Okay. Okay, and then here's just a nice focal disc extrusion. Notice at the L5-S1 level, sometimes you can have very large extrusions that don't really get close to the nerve roots. Now, one thing that you can see is that you can get disc extrusions where the signal intensity within the extrusion is very fluid-like, like this. Some people call these cystic extrusions. Hi, John.
I'm getting my own account, John. I can't fix it.
Okay. Okay, so we'll continue here. So you can get cystic extrusions that look like this. It just, whether it means it's only fluid in it or whether it's just highly hydrated nuclear components, I don't think really anyone knows. I think they're treated as any other focal disc extrusion. And here are some other examples of discogenic cysts here associated with the cysts. And here in the case with a discogram, you can see actually contrast extending into the cyst itself. So these were probably fluid collections and a herniation inside of an extruded disc with nuclear components herniating into those through fissures in the annular fibers. And this is just kind of an indication of how this can occur. Let me see. Shiv, what do you think of this case?
30-year-old male radiculopathy. So it looks like there's an extrusion that looks cystic this time, and maybe a soft tissue component more ventrally. So I wonder if there's a discogenic extrusion or a cystic extrusion with a disc displaced posteriorly.
What's this right here? What is it?
That I think that's hernia, or that's the nucleus that sort of goes through the cyst and.
Yeah, sometimes these can occur, and because it kind of cuts through tissues, these can hemorrhage. And so this is actually a hemorrhagic discogenic cyst.
I see.
And then, yeah, here's another discogenic cyst after surgery. So they went in and removed a extruded disc, and in the area where the disc was, now there's a cystic collection in that area. So it's a recurrent. Okay, Thomas.
35-year-old male, low back pain, radiating to the thigh, onset 1 week, no trauma. So there's also a disc extrusion and looks cystic and a little bit inferiorly migrated.
Okay.
And yeah, it's cystic and sort of right lateral recess.
Okay. And then here's what it looks like at the time of surgery. There's that cyst coming out of the disc. And actually this turned out not to be a cyst. This actually turned out to be an epidural hemangioma that they found at surgery. Yeah. Okay.
"20-year-old male, surgery 8 years ago. that there is a neurocystic lesion at the level of L3, L4. Yeah, maybe a discogenic cystics. Yeah, and there's enhancement too. There's some compression on the ventral thecal sac anteriorly.
And this one they also operated on. They thought it was a discal cyst, and this turned out to be a venous hemangioma. Okay.
Was it the iatrogenics, like secondary to surgery, or?
No, that was a hemangioma, and they went into surgery to remove the disc, and they found that it wasn't really a disc; it was just a hemangioma there. So here we can see on 21403, we can see an extruded disc fragment here on this image. And then if you can see a follow-up about 10 months later as it's no longer there. And what studies have shown is that it's very common for disc extrusions to resorb within a year. In fact, the vast majority of focal disc extrusions will almost completely resolve. Generally, what happens is that the nuclear components, the gelatinous part, is completely resorbed by the body, usually within 9 months. If there's a fibrous component along with it, that tends not to be resorbed, and it gives a residual thing there. In fact, as we'll talk about later when we talk about clinical studies, if you have an acute focal disc extrusion and you elect not to have surgery, at a 1-year follow-up, almost 100% of those will be resorbed. And if you divide patients into those who have surgery and those who don't, at the end of 1 year, there's no difference in the outcomes. So the bottom line is, if you have an acute disc extrusion as a cause of back pain, that has the best prognosis of any cause of back pain because they virtually all improved, and they're all better by 1 year. So if you're going to, in the old days, we thought, well, the worst thing is an acute extruded disc. All those needed to have surgery. They'd compress the nerve. They could have irreversible nerve damage if you don't operate on them within weeks. It turns out that was all wrong, that there is no difference at 1 year if you operate or don't operate. And right now, if you have an acute extruded disc, it's not a surgical condition unless patients have excruciating pain that can't be controlled by any other technique. What the studies show that if you have immediate surgery, you'll get better right away. At 1 year, you're the same. If you don't have surgery, it typically takes anywhere from 1 to 3 months for the pain to substantially decrease. So most people nowadays will elect not to have surgery and will take some sort of painkillers to decrease it. But if those painkillers aren't enough and you really can't handle the pain, then surgery is an option. And so there are multiple papers to show this. Now,
the disc stay abnormal?
The disc stays abnormal. Yeah, you lose volume in the disc, so you get loss of height. You'll get circumferential bulging of the annular fibers typically. You'll get dehydration of the disc, which will go along to eventually completely dehydrated, and the disc space will collapse. When you do that, you change the forces on the facet joints, so you'll get degenerative change of the facet joints. So the degenerative process will progress. So that's why some people and young people like to put in artificial discs, which have pretty much, my experience is that they haven't worked. Though there are people in LA right now who are getting artificial discs placed, especially in the cervical spine. Most of those that I've followed over time will end up destroying themselves and they'll have to have another surgery. If they do surgery, now it's typical you put in a disc spacer. The problem with a disc spacer, it does not allow motion. So that then increases the strain on the discs above and below it. And so typically what will happen is you'll have surgery at the L5S1 level. You'll fuse that level with an intervertebral disc prosthesis to which fuses the disc but keeps the height normal so that it protects the facet joints. But then you've got increased strain at the L4-5 level. So you develop degenerative disc disease at the 4-5 level and then the L3-4 level, and it'll go kind of up the spine. So when you do disc fusions, you substantially change the functional status of the spine, and it clearly leads to more rapid degenerative changes at other levels. If you don't, and you allow the disc to compress, then that also causes degenerative changes at that level. But these in the Western society, almost all men will develop degenerative disc disease, and most women do as well. And that's almost considered kind of normal growth and development now. And when we try to surgically correct that, it's not clear that we're benefiting society in general. You may benefit some individuals, but it's very clear that in many people, you accelerate the degenerative process once you have surgery. So the pathophysiology of disc regression, you get dehydration of the herniated part of the disc, the nucleus pulposus part. When you do that, you resorb the gelatinous portions of the nucleus pulposus. That decreases the volume within the herniated disc, so the herniated disc retracts, but the fibrous annular components are not resorbed and they stay there, so you typically end up with a smaller disc protrusion right at the level of the initial herniation. You can, if you get inflammatory changes around it, which is the areas of contrast enhancement that we saw in those contrast enhanced views, you probably get faster resorption. And you can also get migrated fragments, larger herniations, rim enhancement on MRI. And these, if you have herniations under the age of 40, you tend to have more hydrated nucleus pulposus. But then again, the nucleus pulposus will completely resorb. So here's 52101. We have an acutely extruded nucleus pulposus right in this area. Here we can see it here, and in this area there. And this is 5 months later. We can see it's almost completely resorbed. With a little bit of, if we go back, it's this level, and you can see there may be a little bit of annular thickening here of the fibrous components that remain. But the mass effect has all resorbed in that time period, and that's very typical of acute herniated nucleus pulposus. See, who's next? Okay.
So 32-year-old female with back pain 6 months after MBA. So disc desiccation at L4, L5, and loss of disc height at L5S1. So on the right side, there is a large extrusion. It's extending into the foramen, I think.
Okay, so big extrusion,
right.
That's on 4/14/09. Here we're 3 months later.
It's getting worse.
Okay,
It's migrating cordially.
Yeah, it's migrating cordially. Notice that we have increased volume loss at the level of the disc extrusion. We probably have compression of the nerve roots there. That's 7/13/09, and now this is 11/17/09.
Oh, it's much better now.
Yeah.
Wow.
So it can continue to extrude more, but within a year, they tend to all resorb the nucleus pulposus components. The fibrous components stay and kind of bulge out here. That's what we see. Okay. Here's another patient. Here we can see on 6/22/07, we have an extruded nucleus pulposus here. A few years later, without having surgery, we can see most of it is resorbed. There's just a little bit left there. So disc extrusions. Let's talk a little bit about. Hello?
Yeah, I guess I temporarily lost sound. I can hear you now, though.
Okay. Well, that was just mouthing the words. Okay, so let's talk a little bit about upright scanning. I talked a little bit about this when we discussed the technical component, but a number of years ago we had an upright scanner, and the thought was that if you have upright, you've got more pressure on the disc, and therefore you might be able to see the protrusions better, and then you also might see displacements like spondylolisthesis more in an upright scanner than in a regular scanner. In fact, the concept back in those days was that there are a lot of people with back pain. A lot of those people tend to not have a lot of nerve root compression based upon the MR findings. And the thought was, well, that's because when we're in the scanner, we're lying down, and therefore we're not seeing the disc herniation or the spondylolisthesis. If you actually put them up in a physiologic position where they're standing or sitting, then we would see that disc herniation compressing the nerve root, or we'd see the spondylolisthesis, and therefore MR was missing a lot of symptomatic disease that needed to be surgically corrected because we were not scanning the patients in a physiologic position, an upright position. So we did a series of studies. First one was 50 patients where we did upright scanning. In this case, this upright was actually sitting because we got too much motion if they just stood up. So they were sitting, and then we had flexion, sit at neutral, and then extension views. And then we looked, and occasionally we could actually see that there was a little bit more extrusion in the sometimes we would see more extrusion in the extended position, which is kind of what we expected, but it wasn't statistically significant. But there was a trend towards seeing more extrusion in the supine position, which kind of defied all the logic that we had at that time. And this was a typical example. A lot of degenerative disc disease, kind of a circumferential bulge in the flex position, also probably similar in the neutral position, but we'd actually see increased posterior protrusion in the lying down position and more central stenosis in the supine position. And we actually found more of these than what we expected to see, which was more central stenosis in the sitting extended position. And here's a focal protrusion. Flexion is not as prominent. Neutral, and then in the extended position, we could see a little bit more central stenosis by imaging in the extended position. The interesting thing about this is that the patients who had more extrusion in the extended position didn't seem to be any more symptomatic when we scanned them in the extended position. But here we can see that they're a little bit worse in the extended position. And here's a case where it's severe central stenosis really in all three positions. And then example, and then here the extended. So this was the most severe case that we saw, where we got much more severe central stenosis in the extended position. But the bottom line is the vast majority, over 90%, had no significant change between the different positioning and the supine position. So, and then we also looked at the difference between seated and actually standing, though we didn't do very many standing because of motion. Here's an example where we actually saw in the upright position more prominence of a facet cyst than we saw in the other positions. And then here in the standing position, we could see increased central stenosis and probably increase in the facet cyst versus the sitting position. So there is some differences between sitting and standing. But the bottom line is that, and we also looked at spondylolistheses, and we found no cases where the spondylolisthesis was worse in the sitting or upright position than it was in the supine. I'm sure they exist, but they're not common that you see a difference. And typically, if somebody has spondylolisthesis, it's fairly fixed. And even on flexion extension views by X-ray, we rarely see much of a shift. So what other changes do we look at in the disc besides the contour changes, the disc protrusion that we've been talking about? Well, the other things that we look for, which may be a cause of symptoms in degenerative disc disease, are spondylolisthesis, the degenerative changes we talked about, bone end plate changes, we talked about the high intensity zone, and then also facet arthropathy. And I think these are much more likely to be a cause of most back pain symptoms in patients than the disc herniations are. And these also, according to the study that we'll talk about in a little bit, but that Mike Modick published many years ago, these tend not to get better over time, whereas the acute disc extrusions all get better over time. So if there's anything you want to have if you have back pain, you want a disc extrusion, which, as we talked about before, is my experience as well.
Sorry, that's
yes.
I mean, the extruded disc that gets resorbed then leaves the disc desiccated and decreased in height and everything, and it's a setup for future degenerative change. I would imagine that, if it was just a little bit of a protrusion or something, and the disc didn't actually, herniate, then maybe it would look more normal after a year. Isn't that possible? And it would be less degenerative change in the longer term.
I don't think I've ever seen a disc look less degenerative over time. There always seems to be a progression to more degeneration.
Regardless of the actual herniation through
right. Regards to herniation. Yeah. Well, spondylolisthesis is basically defined as placement. Why don't we stop here, because we're going to start in another term, and we're kind of running out of time. So let's stop here, and we'll start talking about the non-disc degenerative changes as a cause of back pain tomorrow. Okay? Any questions?
Thank you.
Thank you.
Yeah, thanks.
Thank you.
Thanks.